everybody. And this is Dr. Debbie Bush and my colleague and I, Dr. Joanne Flagg. We just got done recording the phenomenal webinar on breastfeeding management of the slow to gain weight breastfeeding infant. So we are now providing case studies and also a clinical resource here for you. This is sort of a post-interactive component to the webinar, and we really hope you enjoyed it. I'm going to go over what resources we have for you, and then we're going to interact with two different case studies. So get prepared, get a paper, pencil, paper, pen, and because we're going to have you interact with this case studies and see if you could figure out what the diagnosis and management and plan are. So our first couple of resources here are to help you in the clinical setting. And these are synopses of what our webinar just went over. So this table goes over potential differential diagnoses or conditions that might be the causative factor for the slow to gain weight infant. So it goes over the different potentials of difficulty transferring milk, potential anatomical considerations, lifestyle factors, and then also any potential previously identified diagnoses or conditions. And then this slide goes over potential differential diagnoses for the maternal or the breastfeeding parent. And then these would include society influences, issues with lactogenesis, be it delayed, incomplete, primary or secondary, anatomical or glandular, physiological, hormonal, or insufficient milk. So these are sort of the main sort of themes. And then in each of these are potential conditions that you may want to consider when you have this dyad situation. This slide goes over the exact or the specific treatment and management plan from the infant perspective. So if you find that you have an infant who's having difficulty transferring milk, they have an anatomical or an undiagnosed, unidentified diagnosis or condition, or if you find that it is potentially lifestyle factors, this helps give you some bullet points of a plan to have, so you have a specific lactation plan. And then this slide is the reciprocal for the breastfeeding parent, the maternal plan. So if you have a parent who has lactogenesis, anatomical glandular, physiological hormone, or insufficient milk, these are the bullet point areas that you want to make sure that you're incorporating into your plan. And then here are the society influences, and then ways to help provide a targeted treatment and management plan for that. So we hope you find that these additional resources are helpful. We are here to help you help your patients. So now let's go into our case study vignettes. And in these case studies, our aim is to collectively analyze the pediatric cases with a focus on lactation and to determine any potential diagnoses and then the treatment and management plan. So we're going to cover two different case studies, and we will go over first the HPI and the past medical history and significant assessment factors. And then I would like you to stop the recording, take your paper and pencil, and think to yourself, now that I just saw those slides and listened to the webinar, what potentially are some differential diagnoses that could be the cause of the slow to gain weight in this infant? And then write those down. Write down potential management plan, a lactation plan, a diagnosis, obviously, and then push the recording again. And we will go over the potential, outcome of that vignette and then see if you were right on target or not. All right. So let's get started with case number 1. So we have for baby A, Abigail, on history. Baby Abigail is a 3-week-old breastfed female, poor weight gain since birth. So she's struggling to regain that birth weight. Normal pregnancy though. Prenatal care occurred. It's a spontaneous vaginal delivery, so it was not a cesarean section. And she has normal newborn screening, so nothing new came up on the state metabolic screening. Abigail is feeding 4 to 5 times a day. Remember, she's a 3-week-old, all right? She's breastfeeding 4 to 5 times a day because her parents are trying to sleep train her at night. Mother reports short feed durations. So when she does breastfeed Abigail, it's very short, so potentially less than 20 minutes. Abigail's slipping off the nipple, and she has some mild nipple pain for 2 weeks. Normal review of systems, though. Nothing outstanding occurred. So on the physical exam, normal anatomy, or no reports of anything affecting, I should say. Orally, no reports of anything with the systems. Everything is normal. Parents report 6 to 7 wet diapers a day and 2 yellow stools daily. No significant family history that would be pertinent or a risk factor for this case. So on assessment, the current weight at this visit is 3 kilos, which is 6.6 pounds. And her birth weight, when noted, was 3.2 kilos, which was just about 7 pounds was her birth weight. So looking at her weight today, you can already determine she has not reached her birth weight. And if you remember from our webinar, we want infants to reach their birth weight at about day 10. She's 3 weeks old. On exam, she's a healthy 3-week-old. Although when observing the breastfeeding, she has a shallow latch, just like mom said, shallow latch, sort of slipping off the nipple. And Abigail seems frustrated at the breast. The physical exam, though, is grossly normal without any significant adventitious findings. So the oral pharynx is normal, cardiac normal, respiratory normal, musculoskeletal normal, no noted torticollis, normal. So we have an infant who has not gained up back to birth weight, a 3-week-old infant, but some of the clues are found in the history. So why don't you pick out those clues? When you did a pre-post weight and you observed the lactation, you noted that less than ½ an ounce was transferred in the feeding. When you showed mom manual expression, they were able to express at about 3/4 of an ounce for manual expression. So that's telling you there's definitely milk there, although the transfer is low. So think to yourself, what could be contributing to this situation? You have a normal PE, stagnant weight gain, and parents are trying to sleep train. So turn off the recording, take a moment to digest that, think of a diagnosis, think of a potential treatment and management plan, and then we'll rejoin and let you know how it went. Okay, welcome back. So hopefully you took some time to figure out what you would think would be the best management plan for baby Abigail. So looking at all of the factors on the previous slide, I hope that you identified that there is inadequate milk transfer, potentially due to poor breastfeeding technique, and possibly a slow letdown reflex. When babies get on with a shallow latch, they're not creating that tight vacuum and they're not transferring the milk. Even if the milk's there, I tell parents often it's like the milkshake suck. So when you have a straw in a milkshake, you initially have to create a really tight vacuum to get that milkshake up your straw, right? So that's a lot of the tight vacuum that infants need to do when they get on the breast. If they have a shallow latch, it's very difficult to do that. Then if mom has a slightly delayed letdown, babies may get frustrated. They may more easily slip off because, the milk's not coming. So those are our potential diagnoses for this scenario. Here is an ICD-10 code that is very relevant to this. You can use the P92.5, which is neonatal difficulty feeding at the breast. I tend to use that ICD-10 code often. So for follow-up and management, we want to think about the lactation plan. So here we want to go back to breastfeeding basics 101. We want to teach the parent a deep latch and an effective positioning. Remember, we had referred to Dr. Morton's perfect latch in our webinar. I encourage you to go back and look at that. You want to teach the parent how to do the asymmetrical roll on, really open that lower jaw down and sort of roll the baby on. We kind of say it's like a sandwich hold or eating an apple. You kind of roll into the baby's head, rolls into the breast so that that nipple goes into the very back the mouth so the baby can get a really good deep latch. And the deeper the latch, the greater the likelihood that good, strong vacuum is going to occur. And once that baby starts with that vacuum, that's going to help get the letdown going, because the letdown is part of a hormonal reflex cycle that occurs when the mom's baby notices that there's nipple stimulation. So that's why it's really key to make sure that that latch is a really good deep latch. And then effective positioning is also important. There's lots of different positions to do. And so you want to do what's best and most comfortable for that dyad. The cross cradle is a really nice starter position. That's when the baby's, held cross cradle and the mom is holding the baby with her hands. But there's also other different positions that are helpful too. So get to know different positions so that you can help the dyad. Recommending manual expression is really important. Manual expression helps stimulate that letdown so that once baby Abigail gets on the breast, the milk is right there. It's a little bit more rewarding for her at first. Down the road, mom may not have to do that all the time, but initially it helps to have some breast milk sort of kind of almost ready to go so that it rewards Abigail to get latched on and start suckling. So that helps to do it pre-feed. Warm pads also help with letdown too. So if you find a mom is cold or she's just, kind of, stressed and anxious, a warm heating pad tends to relax everything, creates a little bit of some vasodilation and help open up the ducts for the milk to flow. Now back to the sleep training. Parents are often very anxious to get the infants to sleep through the night. Breastfed babies are not meant to sleep through the night. They're meant to breastfeed through the night. So we encourage nocturnal feeds, nighttime feeds. Plus, studies have shown the more infants do nurse throughout the night, the more stimulation for prolactin levels, which also help with milk supply. So really educate them that sleep training a young infant really is not fruitful. It's not going to get them to where they want to go. More breastfeeding is going to, because breast milk changes in circadian rhythm. So breast milk has natural melatonin in it, so that the more the baby nurses at night, the more their circadian rhythm will match with the parents, so that they will have their days and nights switched very soon. And then to go on infant feeding cues, make sure that they're aiming for minimally 7 to 9 feeds a day at 3 weeks of age. If not, a little bit more, that's okay too. And try to aim for 15 to 30-minute feeds. Now, I'm not a strict clock watcher with our patients, but we want to avoid the quick 5-minute feed in the young babies, because we want to make sure that they're learning to latch on to take more out of the breast, because the more the breast is drained, the more the breast will make milk. We call it a supply and demand cycle. And then advise the mom on hydration and a well-rounded diet. That's really important. And to avoid postpartum dieting, she will trim up naturally with the extra calories being burned from breastfeeding. I discourage parents from trying to diet and trying to get back into those pre-pregnancy genes. That's not the priority. The priority is feeding the baby and the mental health well-being of the breastfeeding parent. And speaking of that, referring to a breastfeeding support group. Over and over again, research shows that breastfeeding support groups are where it's at to really help support our parents. So in this type of situation, because I felt pretty good about that scenario, I could have them come anytime in the next week. If I felt that mother was a little apprehensive or the parents were a little apprehensive, not quite sure, they could easily come back in another day or two. That's fine. If the parents feel pretty good, they demonstrated that they were able to put baby Abigail back on the breast with that deep latch, then I might stretch it out to a week. But you really want to make sure you're rechecking that weight within a week, though. All right. So it really depends on the responsiveness and how well you think that the parents are able to take what you just taught them and latch baby on and feed her. So on our outcome there, when baby Abigail came back, she did gain weight. In fact, she was very robust and gained about a pound. So that's fantastic. Sometimes you'll see babies who are slow to gain weight have a quick rebound once they start getting those calories, but then that rebound little tapers. Okay. So you may see that quick rebound and then it kind of tapers to the normal 3/4 to an ounce weight gain a day. Mom was effective. The breastfeeding mom was more so effectively breastfeeding. She was following that diet and hydration advice. She was doing manual expression, and especially on the side that she didn't breastfeed, she would get 1 to 2 ounces. That made her feel better. She was able to store that in the freezer, get ready for work. And then we also then discussed returning to work and pumping strategies. A lot of times parents are very nervous about that, and that's on their mind, and that's a stress. So it's important to kind of incorporate that as well, because that's a priority to the parent and to have that mutual goal sharing. So hope you enjoyed this case study. And now we are going to go to our second case study.
Thank you, Debbie. And we'll move on to case 2, which is baby Jay or Jamie. And this baby is a 4-week-old female, and the parent is concerned, and so are you, about the slow weight gain. They were born at 39 weeks, so full term. Birth weight was 3.5 kilograms, 7 pounds, 11 ounces. And the weight at 4 weeks was 3.3 kilograms and 7 pounds, 4 ounces. So the baby should have regained birth weight by 2 weeks of age and be beyond birth weight, and they are below birth weight at this point. They are exclusively breastfed every 2 to 3 hours, and there are brief feedings, 5 to 10 minutes. There's adequate urine output, 6 to 8 wet diapers a day, yellow stools 3 to 4 times a day, which is normal. So the mother may not have been concerned about that. This is a first-time mother with no significant medical history and did not have any postpartum lactation support. So looking at the physical exam and doing an assessment, we have slightly irritable, mildly jaundiced infant with a weight, as I mentioned, of 3.3 kilograms. The length is 50 centimeters, 19.7 inches. Head circumference is 35 centimeters and 13.8 inches. So you would want to plot that on the growth chart to see where it falls. The vital signs are normal, as you can see. There's a normal physical exam, heart and lungs and abdomen. But you do note a shallow, ineffective latch and uncoordinated sucking and slipping off the breast. So this is why it's so important to observe the infant at the breastfeeding. There are no signs of infection or mastitis in the mother. The nipples are slightly sore with some cracking and does appear to be an adequate milk supply as the mother's breasts are full and softer after feeding. So think about what's presented here as far as the history and physical exam, what other information you might want to know, and see what diagnosis or concerns that you come to mind. And we'll take a pause here. So some other questions you might have wanted to know when you were looking at this feeding would be checking a pre and post weight would be helpful, and also checking an oral exam of the baby to see if there's any issues with the mouth or tongue tie. But with this infant, you have a diagnosis of slow weight gain due to ineffective breastfeeding technique and inadequate milk transfer and to post-nipple infection. So the infant is rubbing the nipple against the roof of the mouth and not getting a deep latch into the soft palate. So you would want to make sure that the tongue is normal and make sure positioning is appropriate. So you've looked at the tongue, and the tongue is normal. And so you're going to educate on proper latch and positioning. You can use some pillows for support, offer skin to skin contact, increasing the feedings to every 2 hours a day, every 3 hours at night. Of course, the baby needs to be awake and cooperative with that. But as babies start to lose weight, they also get sleepy. So the more intake they get, the more alert and more effective feeding they will get. And they're only going to be awake for so long for the feeding before they get sleepy. So you want to encourage, 15 to 20 minutes per breast, or at least filling the breast before the feeding, making sure it's softer afterwards. They could do some hand expression. They could pump after the feeding and supplement if needed, especially if the baby is sleepy and not getting a full feeding. They can do some pumping and provide express breast milk through either finger feeding or a paste feeding technique. You're going to have some weekly weight checks and monitor the diaper output and feeding, and follow up with a lactation consultant in a week. You can, as I mentioned, also do a pre and post feeding amount to see what the baby's intake has been, providing resources on breastfeeding support group, having the mom aware and parents aware of feeding cues and what would be an effective feeding, making sure the mother is getting enough rest and hydration and adequate nutrition. So the baby comes back a week later and the weight has increased to 3.5 kilograms, 7 pounds, 11 ounces. So we do expect about 1 to 2 ounces or 1 ounce a day or 1.5 ounces a day. So this is showing improvement. Baby's less fussy, more effective feeding, reduced nipple pain, and you're going to continue to support and monitor them as planned and schedule follow-up weight check and even telehealth visits if needed. So thank you, and I'll conclude at this point.